introduce our session, which is Who's Making the Investment? Eliminating Gender-Related Racial HIV Disparities by Prioritizing Black Women for PrEP Uptake. And I would also like to introduce our guest speaker, which is Dr. Tiara Willie. Tiara, I will stop sharing my screen so that you can share your slides. Thank you so much.
Okay, excellent. Can everyone see the slides?
Yes, thank you.
Perfect. Thank you. So thank you for allowing me to come here today to talk a little bit about the work that I've been doing for the past couple of years, looking at this intersection of intimate partner violence and PrEP uptake, and really trying to center the experiences of Black women. So like the introduction said, the name of my presentation is Who's Making the Investment? Eliminating Gender-Related Racial HIV Disparities by Prioritizing Black Women for PrEP Uptake. So this is what you can expect as kind of like an outline to today's talk. I'm going to give a brief background to intimate partner violence, to HIV prevention, specifically PrEP, and the benefits it potentially can have for Black women, especially Black women who have experiences of intimate partner violence. I'll talk a little bit more about a mixed methods research study that we conducted, trying to really understand what was the relationship between intimate partner violence and women's engagement in the PrEP care continuum across time. And then I'll also talk about some future directions, how this work kind of led me to my current project that I'm doing now with amazing collaborators in Jackson, Mississippi. And then lastly, I'll end with just some questions and some answers, hopefully. So I do want to give just a brief disclaimer that I will be saying Black women. And when I refer to Black women in this presentation, I'm talking about Black cisgender women. So when I say Black, I refer to individuals who have origins in any of the Black racial groups of Africa. And when I mean by centering, I mean seeing the world from these women's point of view and from their experience. So the brief background. So let's talk a little bit about what we know about HIV epidemiology among US women. So what we know is that women represent almost 19% of all new HIV cases in the United States, and that we know that racial and ethnic differences do exist. And so what we know is that Black women are disproportionately affected by HIV. So the CDC suggests that almost 57% of all new HIV cases among women are among Black African-American women. And then we look at the different modes of transmission. What we see is that condomless heterosexual sex is a primary mode of transmission for US women. So what that means is that women are having sex with a male sexual partner and are contracting HIV in that way. So there's a large body of research to date that's really been talking about the role of violence and trauma in women's lives. And intimate partner violence in particular can actually escalate heterosexual transmission of HIV. So what I'm going to try to convince you today is that women who experience intimate partner violence are a very important group for HIV prevention. And I'm going to talk more about Black women who are experiencing intimate partner violence. I'll talk about the prevalence of intimate partner violence in the United States specifically. I'll talk about how it's related to HIV risk behaviors and factors. And I'll talk about the mechanisms that kind of explain why partner violence is related to those risk factors. So first, how do we define intimate partner violence? So intimate partner violence by the CDC is a preventable public health problem, is defined by physical, sexual, psychological abuse by a current or even a former dating partner. And this can be in a romantic relationship or in a sexual relationship. What we know is that at least more than 1 in 3 women have experienced some form of intimate partner violence in her lifetime in the United States. And when you look at this kind of geographic disparity or distribution, you can see that the prevalence of partner violence is not equal across all states or even across all regions. And another thing that stands out to me in particular is that this is descriptive epidemiology. So we like to look at kind of like the distribution of a public health problem. And when I look at the gradient, I see that the lowest value that any state can have is 27.8%. That means there's no state that has less than 25% of women experiencing partner violence. And to me, as an epidemiologist, that means that this is a very important problem that we're not necessarily addressing. So of course, there are racial and ethnic differences in the prevalence of intimate partner violence. So a national intimate partner sexual violence survey that's conducted almost annually provided some estimates on what the rate of partner violence is across racial groups. And if you look at the orange bar, that's the rate of partner violence estimated for non-Hispanic Black women. And what we see is that that rate is higher than the national estimate above women altogether. So it's estimated that Black women experience partner violence at about 44%, as opposed to the 3rd% amongst all national women. So how is this related to HIV acquisition? So there was a nationally represented study that was conducted, really trying to understand, is physical and sexual intimate partner violence associated with HIV diagnoses? And even though HIV diagnoses among this cohort of women was relatively low, what they found is that yes, there is a strong association. So if you look to the right, this light kind of white, light blue bar, those are women who reported physical, sexual, intimate partner violence, and they had a higher rate of HIV diagnoses compared to women who did not report intimate partner violence at all. And so we conducted an additional study to kind of understand across states and across time and across racial and ethnic groups for women, do we see this relationship was significant? And we did. So from 2010 to 2015, across non-Hispanic Black women, Hispanic women, and non-Hispanic white women, and across all 50 states and Puerto Rico, we looked to see if the state level prevalence of intimate partner violence was associated with women's HIV diagnosis rates. And what we found that was consistent across all 6 years was that states that had high rates of intimate partner violence also had high rates of HIV diagnoses among women. And so when we ask this question specifically about Black women, what does the research to date tell us? Well, this is what we know. So compared to Black women who had no experience of intimate partner violence, women that did have this experience were more likely to have a partner that was engaging in other sexual relationships. They were more likely to have infrequent condom use during anal and vaginal sex, and that they were more likely to have more lifetime sexual partners as well. And so when we take all this information in, we're trying to understand, if we want to create interventions, how in the world do we address this situation? Where do we start at? So we have to understand why intimate partner violence is relating to HIV risk factors. One direct pathway that we know of is sexual assault. So sometimes women experience forced sex or sexual coercion by a partner, and this can actually lead to physical trauma of their body and actually help facilitate the HIV virus. We also know that experiences of violence and trauma can also lead to poor mental health conditions such as depression and dissociation. And so it could be difficult to actually even talk about safe sex practices with your partner when you're also trying to manage not only the violence, but the mental health consequences of that violence. We know that some women have tried to kind of negotiate condom use with their male partner, and they're concerned about fearful retaliation or violent retaliation from that partner. And so this is unfortunate because it's making women in these situations decide between being safe from the violence or engaging in HIV prevention. And that's a decision that women should not have to be forced to make. And so what we know from research that's actually talked to men who have used violence against women, what are their sexual risk behaviors? What they find is that men who do use violence against women do engage in more sexual risk behaviors, such as having multiple sexual partners, not using a condom during those sexual encounters. And they're also more likely to have untreated HIV. So I know that was a lot, and I thank you for hanging in here with me. So when I take all of this information in, it's clear to me that we need to be promoting partner-independent HIV prevention methods for women experiencing intimate partner violence, especially Black women who are experiencing intimate partner violence. And this is where the promise of PrEP comes into play. And so I'm sure you all know PrEP is a daily oral medication that can actually prevent HIV transmission. And that there's a number of clinical eligibility criteria that one can meet in order to be a good candidate for PrEP. And I do want to highlight that PrEP is now, that recently their clinical trial was stopped for the long-acting form of PrEP, which is now highly effective among women. And so this is going to hopefully expand options for HIV prevention for women, especially women who may be in abusive relationships who want an invisible form of PrEP, or a form of PrEP that doesn't necessarily need to be monitored by their male partner. And so when we talk about PrEP, we have to talk about the PrEP care continuum. So this is a cascade of events that occur in order for an individual to go from being aware and aware about PrEP, and that is an option for them, all the way to adherence and retention. And there's multiple steps along this pathway. And so what do we know about PrEP among women in the United States? Well, unfortunately, what we know is that it's being underutilized among US women. So women represent less than 7% of PrEP users. And we also know that there are significant racial and ethnic differences in PrEP use among women. Specifically, Black women are using PrEP at rates that are lower than white women, which is not consistent with the HIV disparity among women. So what are some of the reasons why we're seeing this low uptick of PrEP? And so there have been some qualitative studies trying to kind of figure out what has been going on and how can we better reach this group of women that are at risk for HIV. So some of the barriers that we are learning about is that there's concerns about the cost of PrEP. There's stigma related to PrEP as well, and related to HIV. Women just don't know that PrEP is an option for them. And that is also very difficult for women to assess their own HIV risk. And specifically for women who are experiencing intimate partner violence, their risk of HIV actually may increase because of their partner's sexual behaviors. So if they're not completely aware of how their partner is engaging in, for example, other relationships, that may make it difficult for them to be able to assess their own HIV risk. And so despite knowing all of this information, we still think that PrEP could be a viable option for women who have experienced intimate partner violence, especially Black women. Some of the advantages to PrEP is that it doesn't require condom negotiation in the way that condom negotiation in the way that condom use needs to be. So for example, condom use, in order for it to be effective, you have to use it within the sexual act. Whereas with PrEP, you don't have to negotiate it in the middle of the sexual act. And that leads to the other benefit of it, that it's not event driven, it's event independent. So where a condom, you have to use it during the sexual act. PrEP, she can take it at any time of the day and still be protected against HIV. When we talked to women who had experienced IPV about PrEP, few even heard of it or knew about it. But once they learned about it and how efficacious it was, they were very, very interested in knowing more about PrEP and trying to understand how it could be feasible for them, because they had concerns about their partner's controlling behaviors. And they wanted to know who was going to help them out if they were going to actually go through the PrEP care continuum. So this led me to ask several questions that when I looked in the literature, I didn't really know the answer to. And the question is, you know, PrEP is such a viable option, but is it going to be feasible for women in their lives, especially Black women who are experiencing partner violence? And will women actually use it? So that's the reason why we conducted the Her PrEP, Her Way study, to be able to figure out how is intimate partner violence shaping women's experiences as they're engaging in the PrEP care continuum. So we conducted a prospective cohort study. We started in 2017. We did baseline surveys and then a 3-month survey later on. And then from the women who completed the cohort study, we invited a small group to do semi-structured qualitative interviews, to really understand more about how the relationship, the provider, and societal level factors influence their decisions around PrEP. So to be included in this study, you had to identify as a female between the ages of 18 and 35. You had to be eligible for PrEP based off of the 2017 PrEP CDC guidelines. And we were interested in partner violence. So when we recruited women who had those experiences, we were specific to physical and sexual partner violence. And because we wanted to see if the partner violence and HIV risk factors that would make them eligible for PrEP occurred within the same timeline, we ended up keeping it within a 6-month time frame. Women were recruited online, and they were also recruited in the community in New Haven, Connecticut. They completed online and in-person surveys. The interviews that were qualitative could be done in person or over the phone. Women were compensated with gift cards, and they were also provided a resource guide. So some of the survey measures that I'll talk about in this presentation will include background characteristics such as age, race, ethnicity, and education, experiences of intimate partner violence, physical and sexual abuse, PrEP care continuum indicators, specifically HIV-related worried, PrEP awareness, and PrEP intentions. And so the question that we had is we wanted to be able to estimate the causal impact of intimate partner violence on the early stages of the PrEP care continuum, the awareness stage. And when I say causal effect, in epidemiology, in order for us to say that a predictor causes something to happen, we have to use the golden standard, which is a randomized controlled trial, where you will randomize a group of individuals to a treatment and then randomize them to a control setting. Well, unfortunately, in violence research, we cannot randomize individuals into violent relationships and not violent relationships. That is not realistic and is unethical. And so causal inference is a sophisticated statistical kind of package that allows us to be able to estimate the causal impact of a predictor using observational data. So it still allows us to make strong statements about our significant findings without having to use the randomized control trial method. And so that's what we did in this paper. So the women that were included in our study, there were about 218 women around the age of 25, a very racially and ethically diverse group of women. The majority of the women had less than a bachelor's degree education, but the majority of the women were employed. They had at least a $30,000 annual household income, and the majority of the women identified as heterosexual. So this is some of the bivariate results that we found. So we looked at the PrEP care continuum indicators and looked at differences between women who reported intimate partner violence versus women who did not report intimate partner violence. And what we found, if you look to the far left, the dark orange bar is for women who experience intimate partner violence. What we found is that that group had a higher prevalence of being worried about an HIV infection within the next 6 months compared to women who did not have those experiences at all. And if you go to the far right side, you'll see that women who experience intimate partner violence had a higher prevalence of being willing or having intentions to use PrEP compared to women without those experiences at all. And so we ran our sophisticated causal inference model. And even though PrEP intentions was significant in the bivariate model, what we found in this causal inference model was that HIV-related worry was statistically significant. And so what this means is that we had really strong evidence to suggest that women who experience intimate partner violence were very worried about getting an HIV infection within the next 6 months. And so it was clear to us from this data that partner violence is undermining women's sexual health. They have greater worries about HIV infection, and this may be due to a multiple of things, right? So it could be because they're aware of vulnerabilities to HIV, such as their male partner's risky behavior, but it may also be that women themselves are engaging in risky behavior as well. So we knew that there were a couple of things that could be going on to be explaining this relationship. We also found that it was interesting that the results were significant for HIV-related worry, but not necessarily the other steps along the PrEP care continuum. And so we were trying to figure out, what is going to be needed to help move women from the HIV worried area to actually receiving PrEP. And some initial thoughts that we thought about was like, how could we build violence-informed approaches around the PrEP care continuum? How could we combine trauma-informed care with PrEP navigation models, potentially to help move women along that PrEP care continuum if that was their choice? So our main takeaway was that we know women who experience intimate partner violence are worried about getting an HIV infection within the next 6 months, but that isn't necessarily translating into receiving a PrEP prescription. And what we also didn't know much about was, even though we had almost a fourth of our sample identified as Black women, we didn't know if these relationships really spoke to the unique needs of Black women. And we were interested to really understand if that relationship was consistent. So in order to answer that question, or both of those questions, we conducted 2 additional studies, and I'll talk about each of the studies. The first study we conducted was trying to understand if experiences of intimate partner violence were associated with PrEP interest and PrEP acceptability among Black women. So this was a secondary data analysis of a study that was conducted in 2014, where they did a one-time cross-sectional survey. The participants were self-identified Black women between the ages of 18 and 25, so a very young sample of women. They were recruited using flyers from community-based organizations in Baltimore, Maryland. Women were compensated with gift cards and were provided a resource guide. And the question that we had was, is there an association between PrEP interest and intimate partner violence for Black women? And so our sample included 147 self-identified Black women. The average age was about 21 years. The majority of the women did not have a high school education or a GED. The annual household income was a little over $13,000 a year. And the gender of the sexual partners were majority of women reported men as their sexual partners. So what do we find at the bivariate level? So what we found, and if you look at the graph, so the dark orange bar to the far left is the full sample. So everyone in all 147 women. The bar in the middle, which is kind of like a medium orange color, includes women who reported intimate partner violence, and the light orange bar are women who did not report intimate partner violence. So if you go to the far right and you look at the willingness, when this is the group of women who were willing to use PrEP, what we find is that women who reported intimate partner violence were more willing to use PrEP than women who did not report those experiences. And that was among all women who were Black. And then if you go to the far left, which is not willing, you'll see that there was a much bigger bar, which represents Black women who did not report intimate partner violence. They were more likely to say they were not willing to use PrEP. So we thought we could take away from this that there is high acceptability of PrEP among Black women, especially Black women who have experiences of intimate partner violence. And what we're thinking is what happened is that the violence and the trauma that they're potentially experiencing may be influencing their understanding of their needs for HIV prevention. So again, when we talk about violence-informed approaches to PrEP, we feel like this could be a useful strategy for Black women, but recognizing that this is beyond, there are other social and structural factors beyond Black women's control that also could be impacting their HIV risk and their ability to even receive PrEP. And so we're trying to figure out how can we build this kind of multi-level model that's really being comprehensive of the multiple barriers that Black women have to engage with in order to receive PrEP. So to be able to answer that question, we conducted an additional study with the qualitative data, really trying to understand the different levels, the ecological levels. And what I mean is how the relationship level, the community level, the provider level, and the societal level influence women who experience intimate partner violence, their ability to even receive PrEP uptake. So that was what we tried to do. So in this particular study, we've received so much rich data from this qualitative interviews, we had to break it up into 2 separate papers. So I'm going to present on the paper that talks about how the relationship level factors influence PrEP awareness, interests, and intentions among women experiencing partner violence. And the questions that related to this area were questions on relationship dynamics, communication with women's partners about STD and HIV prevention, thoughts on and experiences with PrEP, and of course, barriers and facilitators to PrEP uptake. In order to participate in this survey, you had to have participated in the previous cohort study we conducted. And so we recruited women from that cohort study if they have reported partner violence in their baseline survey. So these women were purposefully recruited. And we've actually reached the MADIC saturation at 19 interviews. So we stopped doing interviews at that time. So who were the women that participated in these 19 interviews? So their average age was about 26, which is a little bit higher than the 2 previous studies. The majority of the women did identify as non-Hispanic Black. The majority of the women did not have a bachelor's level education. The majority of women were not employed at the time. And the majority of the women did have an annual household income above $30,000. So we had at least 5 themes that emerged from this data set, from the qualitative stories that women shared with us. And so I'm only going to share 3 of the themes just for time's sake, but I'm happy to talk more about them if we have time at the end. And so there's three different themes. So the first one, going from the left to the right, is about relationship power dynamics and how that influences women's intentions to receive PrEP. The theme in the middle showcases fearing the unknown, which actually came verbatim from some of the interviews where women talked about concerns about infidelity, potentially being a motivator for receiving PrEP. And then the last theme to the far right talks about how male partners' reactions to women's interest in PrEP can actually sway whether women take those additional steps to receive a PrEP prescription and having conversations with their provider. So that first theme, so what we could tell was that relationships and the dynamics, who has the most power in the relationship, can shape whether women have actually access to PrEP. So Stephanie describes her partner's inability to compromise. He's not willing to change or budge either. What he says is what it is and how it goes. And it can be a little challenging at times. And so Stephanie is talking about, this is how her relationship is. Her partner exhibits a lot of controlling behaviors. He potentially monitors her well. And so when we take those behaviors in the context of the PrEP care continuum and the various steps that are needed for women to not only become aware of PrEP, but then engage in it and stay retained in care, it may be difficult to do that with a very controlling and monitoring partner. Some women also talked about fearing the unknown. So they didn't know what was happening when their partner wasn't around or would come home late. There were suspicions about their partner being having multiple sexual relationships. And so in this sense, if there are concerns about infidelity, women did talk about PrEP being a good option for them. So Monica describes PrEP as a way to protect herself from her partner's infidelity. I'm currently single. Although I just want to be with one person, sometimes it doesn't end up that way. I may know someone on one level, but then I don't know what they are doing when I'm not with them. I would like to be protected by PrEP. And so again, Monica is explaining to us, it's really complicated to be dating or to be in a relationship, but she sees PrEP as a positive thing. It's a way to protect herself. And then women, after they talked to us, so the majority of women who participated in the cohort study did not know about PrEP. So they learned about PrEP by participating in their study. And some in our study, and some of the women went back to their partners and talked to them about PrEP. And they got varying reactions from their partner. And so what was clear to us was that depending on how the partner reacted, that may actually, depending on whether the partner was supportive versus not being supportive, would actually influence whether women would go get PrEP or not. So Nicole's partner perceives her PrEP interest as a sign of mistrust. So I did mention it to him. I asked him what he thought about it. He was like, well, why do you want to do that? Do you not trust me? I was like, no, it's not about trust. Just things happen sometimes and you're gone all day. You never know what may happen, what could happen. And so this is Nicole even just bringing up the topic of PrEP to her partner immediately brought up concerns about mistrust in the relationship. And it was concerns about mistrust that she might not necessarily feel comfortable to talk about, because again, these are women who actually reported recent physical and sexual abuse in their relationships. So what do we take away from this? So it was clear to us that women's autonomy in their relationship was very complex, and that it's really relationship driven and relationship dependent. And that if women overall don't feel that they have autonomy and agency in their relationship, they may feel uncomfortable initiating conversations about PrEP with their provider, which in some instances may be a first step to having an honest conversation about sexual risk histories. We also know that there are some women that are concerned about infidelity in their relationships. And so for those women, PrEP could be, really helpful for them, and really could be having honest conversations about infidelity could potentially encourage and motivate women to get on PrEP. Because if they get on PrEP, they may be able to even avoid having conversations altogether about infidelity with their potentially abusive partner. And there is some research to suggest that if women talk about infidelity with their partner, there's a fear of violent retaliation for bringing it up, or it gets reversed back on them and the partner starts accusing the women of having other relationships. So PrEP in a way could help women avoid that altogether. Male partners are really influencing women's PrEP intentions. And part of this, for women who experience intimate partner violence, there is a fear of like a partner retaliating against them, which could also lead to PrEP non-use. Because again, these women are having to juggle between relationship safety in HIV prevention. And so when we talk about, the different barriers, potential barriers and facilitators to PrEP uptake for women, we have to think about like how are women's relationships and those challenges interfering with women's autonomy and agency to actively use PrEP. So just to kind of bring it all together, some takeaways that I took away from these studies was, women who experience partner violence are concerned about receiving an HIV infection in the next 6 months, but that isn't necessarily translating into receiving a PrEP prescription. And what we're finding is that these relationships are very complex, and that there's multiple things that potentially are going on. And if we're not taking the time to really help women navigate and plan through their relationships in the context of HIV prevention and violence, then we may not see them actually receive a PrEP prescription. So that led me to asking several things, but one of the things that I wanted to share is that I tried to figure out, okay, if we know that this is what's going on, if we have an idea that this is what's going on, especially for Black women, what is the best way for us to deliver information around PrEP and really help women be motivated and gain access to PrEP? And what is the best strategy? What is the best strategy? Like, where do we go and what do we do with this information? And so I've done a number of epidemiological studies and qualitative interviews, and I feel like we are getting information. Women are telling us what they want. We're getting information for the next steps, like what are the next things that we're going to do to really help turn the tide and help women get on PrEP. And so this is where I think it's really important for us to think about ways that we can prioritize PrEP to address these disparities in HIV prevention by focusing on the unique needs of Black women and about centering Black women in their experiences, and recognizing that there are multiple level interventions are going to be needed to address the various factors that really try to constrain Black women's agency and their ability to actually receive PrEP. And so that can include a number of things, including gender roles, it can include stigma, what we're seeing with intimate partner violence, but also trying to understand how experiences of racism and sexism can also impact Black women's healthcare experiences when they need to talk to a provider about their sexual risk and their violence experiences. How are we having those conversations? Are we creating an environment where Black women feel safe and they feel supported? And I talk about the clinical setting as a potential entry point. So, and there's a couple of reasons why. So healthcare providers are really the gatekeepers to PrEP right now. In order to receive PrEP, there needs to be a conversation with the provider that feels that, women are a good candidate for PrEP. And unfortunately, the CDC PrEP clinical guidelines at this point do not include intimate partner violence as an important criteria for helping us to identify potential candidates for PrEP. And so what I feel as well is that since intimate partner violence screening isn't routinely done in all clinical settings, that some women who are good candidates for PrEP, in particular Black women, may be missed as good candidates for PrEP because of the lack of screening. So all of this work to date has kind of led us to a pilot study that we're trying to start now called Using Implementation Science to Increase PrEP Uptake Among African American Women, what we've coined as the Sister PrEP Project 2. And so this project I'm doing with amazing collaborators and community stakeholders in Jackson, Mississippi. We're going to be working together to actually conduct qualitative interviews with Black women who are patients at community healthcare clinics and also the clinical staff there to kind of understand from their perspective, what can we do? What are your recommendations for increasing PrEP uptake among Black women, recognizing that there are potential histories of violence and trauma that may need to be discussed in these conversations around PrEP and sexual risk. And so the goal is really to create a trauma-informed PrEP implementation toolkit that can be used in clinical settings to help Black women feel supported when they talk about their HIV risk, and also to feel supported when they disclose experiences of violence if that's what they want to do. And so I just want to take some time to just acknowledge all the various like study participants and research teams, of course, the funders that funded these various projects, amazing collaborators as well. And with the, let's go back real quick, with this study here, we're just rolling it out. So we're really excited about the potential that it has and the innovation behind it. We're just kind of combing through some of the data now. And because I like to take a racial and ethnic equity perspective to my work, I won't share any of the preliminary findings just yet because I want to talk it through with my community partners to get their perspectives that may be completely different from mine. But thank you for your time, and I'm happy to answer any questions if there are any.
Thank you so much, Dr. Willie. It looks like we do have a couple questions in the Q&A. Are you able to see those?
Oh, yes. Okay, I'm here. I can see these. Okay. Should I stop sharing or?
If you want to, I mean, this is great to have your contact information up if people want to take it down while you're answering questions.
Okay, awesome. So you mentioned, okay, so you mentioned 0.6 women with sexual license. Question following, do we know any specific demographics? Oh, okay, this is a great question. So this is asking about the slide that I showed in the very beginning. I don't know if I can get in the very beginning, showing the rate of HIV diagnoses among women with and without experiences of partner violence. So that was a nationally representative sample. And when they did those analyses, they actually controlled for those demographic variables. The question is, do we have any specific demographics within this 0.6? I don't believe in the paper that they specifically gave us the demographics in that 0.6. And I think that might be because they controlled for those variables in their model. Is there any data on women who use PrEP prior to entering relationships and how they navigate those conversations? That is a great question. So I guess my reaction is going to say no. No, there's really not any data on women who have used PrEP prior to entering their relationships because there's just so few women who have ever used PrEP just nationally that the rates are just so low. We would have to do some fancy kind of like retrospective cohort analyses to kind of go back and ask those women and try to figure out the timing. And I don't think anyone's ever done something like that, but it would be, I like the idea of doing that. So we call that like kind of like a positive deviance approach where there has been a group of women who have been able to engage in those conversations and what strategies did they use? Because maybe we can, disseminate that to other women when providers are having conversations. But we don't know. But I would be so interested in doing that project. I think it was Sean. Reach out to me, Sean. So this is such an excellent presentation. Oh, thank you, Latino, thank you. Studies are really good. Do you have any thoughts about providers discussing PrEP with Black cisgender women using the tiered effectiveness approach, similar to contraceptives, and how that can be, how that can also be experienced as coercive is something I would like to know more about. So just to be honest with you, I am not familiar with the tiered effectiveness approach. So I don't know what that is. So it's a little difficult for me to have that. But I think our hope is that when we have these qualitative interviews with clinical staff and with women, we'll be able to kind of triangulate the consistencies and work through the discrepancies between the two of them, between the two groups, because we want to be able to create a conversation that makes sure that women feel empowered in the conversations. And I think that might be what you're trying to get at, is kind of like a power dynamic between the patient and the provider. And we don't want to exacerbate that. So that's why I think it's going to be very important that if we're going to center Black women, we have to understand, you know, what they feel comfortable talking about and how they want to talk about it. Any cases of depression in women with Truvada for PrEP? So this is something that I've also had many questions about, is kind of the mental health symptoms among women who use PrEP and who don't use PrEP. I believe there was one study that was recently published that looked at depression specifically among transgender women. And men who have sex with men, I believe, in one of the clinical trials. But when we talk about cisgender women, from my understanding, that is an area that we just have not explored yet. So we actually don't know. Yeah, but these are great questions.
Just as a clarifying point, the person who asked the question about the tiered effectiveness approach,
Yeah.
they shared in the chat box that tiered effectiveness approach is a way of providing information with the most effective prevented first, but in reality, the most effective is what's going to work for somebody.
Right, I see. Oh, yeah. So yeah. Yeah, so I can see why that would happen though. Um, I think for the work that we're trying to do, if we want to have change, we have to, you know, give all the information to women. So let them know of all the different methods that they can choose from, and help facilitate the conversation with them on like what's going to be best for their relationship. I'm not completely convinced that saying that like, hey, PrEP is going to be the best method for you. I think we have to make sure that is, because everyone's relationship is different. So I think we have to make sure that is as individualized as possible. And so that may just include telling women about all the different methods and the pros and cons to it. And this is kind of in the sort of doing a decision aid with women, but not in that formal sense. Yeah. Oh, does the so I got some questions. Does the cost of PrEP pose any issues to women trying the prescription? I hear that it is expensive. So PrEP can be expensive. We've started doing interviews in Jackson, Mississippi with women who have used PrEP, and they have shared with us that PrEP was either a very low cost or it was free. And they had an amazing PrEP navigator that helped them complete the paperwork needed so that PrEP could be free for them. So what we're hearing from the women who did kind of make that transition to actually being worried about HIV infection to actually receiving PrEP is that cost was definitely an important component of it. And for those women, when it was free, they were able to receive it. Got more questions. Let's see. I'm missing confirmation criteria for the complete understanding. Oh yeah. So I'm sorry, you didn't miss any information. Let's see, did I? Let me see. Ooh. Yeah, so I did not list the inclusion criteria for the study in Jackson, Mississippi, but we're essentially recruiting African American women over the age of 18 who are seeking care at one of our collaborating community partners in Jackson, who would be eligible for PrEP based off of the CDC guidelines. Okay, what is your take when a 13 or 36-year-old is interested to be on PrEP, and how will it be the right approach towards these cases? I'm not sure I completely, are you asking me about just adolescents being on PrEP and my thoughts about adolescents being on PrEP? Maybe. Yes, okay. Okay, great. So the advocate, the public health advocate in me would say that if PrEP is safe for adolescents, and if adolescents are engaging in high risk behaviors that may put them at risk for HIV, then we should be having conversations about PrEP being an option for adolescents if that's what's best for them. Um, I I think when we start getting into the place where we start picking and choosing, we start cherry picking the best person, then we can lead to inequities against group. And I would not want to see that. I think we should have equitable access to interventions that are going to help protect us against HIV. And so I know that could be very controversial, especially for adolescents who ideally are living at home with their parents and are navigating that particular family dynamic. But as far as public health and primary prevention of HIV is concerned, if PrEP is a good option for them, I think we should be having conversations with adolescents about it. Thank you for this. Oh, what is the projected timeline for y'all's implementation study in Jackson, Mississippi? Yeah, so we just started. Thank you,